Hello, dear colleagues. My co-chairman, if you allow me, I would be speaking Russian. I'm happy to welcome at our today's scientific and practical conference with international participation of TIREO Academy that we have for the second year in a row together with Berlin Chemie Company. And for that, I would like to thank Iroda Suratovna and her team. The conference is going to be dedicated to... I cannot skip politics. Today, the problems are so pressing, especially thyroid diseases related issues. Today we have international speakers in offline format and I hope also online format as well. This is Professor Leonidas Duntas. He is the Secretary of European Thyroid Association, Professor of Endocrinology and Internal Medicine in the Genzion Hospital, Unit of Endocrinology, and Diabetes and Metabolism and Thyroid Section, University of Athens in Greece. Also Professor Gulnara Rahimova, Doctor of Sciences, Professor, Head of Chair of Endocrinology, Center of Development of Professional Qualification of Medical Employees, and by particular reasons our colleague Professor Troshina Ekaterina, corresponding member of Russian Medical Academy of Sciences, Deputy Director of Endocrinological Institute, who was dealing with the thyroid gland issues for many times. She is a student of Mr. Islambekov. I hope she would be online with us, right? And during today's conference, we are going to talk about the issues of thyroid diseases, thyroiditis, replacement therapy, and I am the cardio surgeon. One of the organizers are surgeons. We will definitely take a look at the cardiovascular risks. And it was a pleasure that before the conference, during our communication, previous talks, dear professor, having known that what specialties we represent, has joyfully presented the following conference or other conference in comorbid state, the issues of cardiovascular pathology. And so I'm kind of announcing to you right now and giving to you some preliminary details. So given the big attention in our country, it's not a secret that from our president and the government, they dedicate big attention, not just the medical issues and healthcare in general, but in the endocrinology, the prevention and treatment of endocrinological diseases. I think it would be interesting for not just endocrinologists, but for the adjacent professions. Doctors, if you allow me, let me give a welcome speech to Mr. Professor Leonidas Duntas. For those who would be interesting or who would be hard, we will have headsets for simultaneous interpretation. You'll have managed to get them, no problems. Please, Professor.
Ferus Faktulievich and Professor Rahimova. Thank you very much for the introduction. Dobry dzień, salam alaikum, ladies and gentlemen, dear colleagues. It is such a privilege to be here with you today. I thank the organizers for their most kind invitation, and I extend to you all a very warm welcome to this meeting. I would also like to thank Berlin Chemie, particularly Velizar Hulev in Berlin, and also Malika Kamarova and all the team for their initiative to organize the Thyroid Academy in Uzbekistan and for generously support the meeting. So, I'm very pleased to be in Tashkent for various reasons. It is a wonderful opportunity to meet with you all today and discuss the thyroid and its diseases, sharing, as we do, not only a common interest in the regulation and prevention of thyroid diseases, but also a passion for science and for the thyroid gland. I'm particularly interested in the epidemiology of thyroid diseases in Uzbekistan, as there are no data, in its iodization program, and in the modalities of treatment applied in this country. In times of war, suffering, and of injustice, it is of utmost importance to stay united, to work together as doctors, preserve not only our dignity, but also care for our patients and for all those who are in need. For a second reason that I am happy to be in Tashkent today, it is because of Tashkent. It is an old city with wonderful inhabitants, with such a long history, going back many centuries. For 2,000 years, Tashkent has been a crossroad between different cultures and religions. And historically speaking, there are quite strong ties between Uzbekistan and Greece. Indeed, and notably, this region, when forming part of the Persian Empire, was briefly conquered by Alexander the Great, while later it became part of the Greco-Bactrian kingdom. Following the Second World War, Tashkent received thousands of Greeks who settled here and influenced the growth of the city. And finally, the third reason, I am delighted to be among the people of Uzbekistan who are famous for being wonderfully hospitable and hardworking. So I would like to thank you all once again, and please feel sure that we will enjoy a highly successful event. Thank you very much.
Thank you, Professor. You start.
Do I have a pointer or
This is the next slide?
the next
Right, this
slide?
one? Yeah, this next slide is the best slide.
Thank you. Now,
Okay. Сейчас мы сразу, профессор доложит нам.
So Professor will give us a presentation about autoimmune thyroid disease. Yeah, please, Professor.
we're going to talk about autoimmune thyroid diseases. Particularly, we will review Hashimoto thyroiditis, which is, as we all know, the most common thyroid disease all over the world, not only in Central Asia. But do I have the English version? Can I have here the English version maybe, in order to understand? Malika, here, only in the computer, just to have my slides.
The English version to hear.
Okay, yes, very good. Yes, thank you. Thank you.
Он увидит?
А видит, если ему видно не будет, может ноутбук ему поставить.
Can you see?
It's, no, I can see very well, but they are.
Just
Yes, it's okay.
Um.
No, I was saying that we will review Hashimoto thyroiditis, mainly Hashimoto thyroiditis. But we'll also going to have a look on polyglandular autoimmune syndrome, a few words about its pathogenesis and clinic. We will discuss about the etiopathogenesis, degrees and symptoms of Hashimoto thyroiditis, but also of modalities of treatment. But before going to the presentation, please let me introduce you Benjamin Franklin, who was really a very gifted polymath. He was an author, he was a statesman, he was a diplomat, he was an editor, he was a poet. And he was saying that, tell me and I forget. Teach me and I may remember. And involve me and I will learn. And that's what I'm going to do today with you. I will involve you in my lecture because I wouldn't like to stay here and talk, but I will ask you. So we can communicate and we can interact. So let's start with a presentation. A 44-year-old male presented in the outpatient clinic with fatigue, dizziness, sleepiness, vitiligo in the extremities and face. He reported weight loss of about 6 kilos in the last 4 months. His mother had Hashimoto thyroiditis. No disease in the anamnesis, no drugs. The clinical examination revealed vitiligo in the extremities and face, as said before, hyperpigmentation in the heart. The blood pressure was 90 to 65, and the heart rate 60 beats per minute. Blood sugar 78 milligrams per deciliter, no goiter by palpation, and no cardiac pathologic findings. Well, of course, the first thought might be that he suffers from hypothyroidism. But can you imagine something else? Because, please, underline the blood pressure was too low for hypothyroidism. Because as we know, hypothyroidism, in hypothyroid patients, the diastolic is slightly or borderline increase. And the people the patients with hypothyroidism do gain weight, do not lose weight, 6 kilos in 4 months. So maybe we can have a second thought. So please, can someone suggest something or something to look after? Excuse me? Yes, anemia might be, but severe anemia. And
Cortisol.
very good. So Professor Rahimova proposed cortisol. So the laboratory findings, first of all, TSH12, so indeed, the patient had hypothyroidism. 3T4, borderline normal, but 0.8 to 2.2, the normal range. Thyroid antibodies clearly high. and natrium 130, calcium 41, and blood sugar 77. More examinations, cortisol was proposed. Cortisol, the basal cortisol, was 2 micrograms per deciliter. The eosinophils, 9% increase. Cholesterol, 232 milligrams a deciliter. HDL, 51. LDL, 165. This is aligned with hypothyroidism. As we know, hypothyroidism is increasing cholesterol, particularly the low-density cholesterol. So the patient has a profile of hypothyroid, but he has also very low cortisol. What is that? Does anybody has a suggestion for the diagnosis?
Аутоиммунный, я не знаю, как по-английски это сказать. Аутоиммунный надпочечниковый недостаток.
Yes. The patient has the patient has autoimmune thyroiditis, clearly, and he has very low cortisol. So there is a case, I picked it from hormones that we have received here in the last year. He was a patient who corresponds, who reflects our patient, presenting hypopigmentation and hyperpigmentation. So vitiligo and hyperpigmentation. You can see the left hand of the patient with hyperpigmented areas. And you can compare with the right hand, who is the hand of a Danish patient, and you see the typical Nordic derma, very bright. So the hyperpigmentation is due to increased ACTH, and such a dermal manifestation of disease. What is this disease? Coupling autoimmune thyroiditis with adrenal insufficiency. Probably, we have not measured the antibodies against the adrenals, but probably it is an autoimmune disease. It is the so-called Schmidt syndrome. It's a biglandular disease which has been published in 1926 in Munich by Schmidt, who described first 2 patients with non-tuberculous Addison disease and thyroiditis in both organs. Lymphocytic infiltration was also found. If you add diabetes in this biglandular disease, you have the so-called Carpenter syndrome. Well, adrenalitis, thyroiditis, and diabetes mellitus. Okay, this has been so diagnosed in a second stage because the assistant who has investigated the patient has concentrated on hypothyroidism, but then as we saw that the patient was also hypotensive and who was very tired, exhausted, we proceed with the analysis, and we could find that he has a Schmidt syndrome. What do we do in such cases? How do we treat them? Of course, we should start with hydrocortisone, 20 milligrams a day, 10, 15 milligrams in the morning, and then 5 milligrams later in the afternoon. Levothyroxine can be applied, calculating a dose of 1.6 microgram per kilo per body weight. It is very important, do not start treatment concomitantly, because if you add thyroxine before patient has been stabilized by providing him with hydrocortisone, you could induce an adrenal crisis. So we start for a week with only with hydrocortisone. We stabilize the patient, and then we proceed with treatment with levothyroxine. And this belongs to a family of diseases, the so-called polyendocrine syndromes. This is the autoimmune polyglandular syndrome type 2 in the central of this tape. There is the autoimmune polyglandular disease type 1, which is characterized by Addison disease, hypoparathyroidism, chronic mucocutaneous candidiasis. You can see the typical age of onset. It is the type 1 primarily in childhood and in the adolescence. And type 2 is mainly presented in adolescents and adults. And there is the third part, very rare, which is present only in infancy. The frequency is one. It is a mutation, most frequently, of the autoimmune regulator, the IRE, which may, by mutated, can induce the autoreactive T cell, which then destroy thyroid or the adrenals. And then we have, this is mainly driven by the central T cell tolerance. And the periphery, we have the autoreactive T lymphocytes, which then by inducing the antigen-presenting cell, the blue circular, which may increase the transcription, the expression of the transcription factor FOXP3, enhancing, increasing the T regulatory cells, which may then stop the self-destruction of T cell in the periphery. Interesting that you know that Beethoven, Ludwig van Beethoven, was deaf. And there have been a couple of studies suggesting that he might have had an autoimmune hearing loss. This may happen, the so-called sensorineural hearing loss. It is very rare, but what speaks against is that in this case it is a progressive, it is a sudden, excuse me, it is a sudden deaf loss. The hearing is suddenly stopped. While Beethoven was, since his youth, was losing his hearing. So probably it was not by autoimmunity, but there have been some publications, particularly in the 90s, suggesting, proposing that Ludwig van Beethoven had autoimmune deafness. Just as an anecdotal saying. And now we're coming to the main part of this lecture, which is the autoimmune hypothyroidism or Hashimoto thyroiditis. You see, the world prevalence of this disease is the most common thyroid disease, and probably the most common endocrine disease, together with diabetes mellitus type 2 on a global basis. You can see the various incidents all over the world. Please look at the Western Australia, who has a very high incidences compared, for example, to Denmark. Western Australia, 273 cases per 100,000 people, while in Denmark, 28 per 100,000 people. Why? What is the main factor? Iodization. And in Western Australia, the iodine intake is very high. And in Denmark, it depends on the region. Copenhagen has a high iodine intake, while Jutland has a very lower, so the middle, the average was is lower, is 28. The same is Spain, also various differences among the various regions and populations in the country. So it is important to keep in mind that thyroiditis is a very common disease, the most common thyroid disease, and is variable depending on iodine intake. There are no data, I repeat, from Central Asia. We do not know. We suppose that the incidence is low because the iodine intake is low. And we very much hope that by increasing the iodine intake in the next years, we will have as a side effect, as an acceptable side effect, an increase in autoimmune thyroiditis. Here is the summary of the genetic, environmental, and existential factors which been associated, induce Hashimoto thyroiditis. We see the various genes on the left side, the many environmental factors, and the existential factors. If you have a genetic predisposition from your mother, for example, then you have 50% chance to get autoimmune thyroiditis, depending on the environmental factors. Stress is very important, iodine intake, and selenium and vitamin D, together with pregnancy, are the most important environmental factors. Here, we say that the autoimmune disease is mainly subdivided in Hashimoto thyroiditis, the most common, and the Graves' disease. The difference in etiopathogenesis of these diseases is that the CD4 cell recruit the beta cell and the CD plus A T cell in the thyroid. And then by auto-reaction in the thyrocytes, involving also the plasma cells and the cytotoxic lymphocytes, the thyroid cells are depleting, are destroying by these cytotoxic lymphocytes and the autoreactive antibodies pathway. So both are autoimmune diseases, the most common autoimmune diseases, hypothyroidism and hyperthyroidism of autoimmune etiology. Here is a flow chart of the events. I would like to really that you take a good look at this etiopathogenetic mechanism, because in the future we may have drugs who may be involved, stop, influence one or the other of this cascade of events. We said that the environmental and genetic factors are combined to damage thyroid cells and provoke antigen release. They are presenting in antigen-presenting cells, and the thyroid is infiltrated by antibodies and T lymphocytes and beta lymphocytes. And we have then the predominance of Th1 or Th2 cell with the following cascade: the cellular immunity or the humoral immunity, acquired or innate immunity, thyroid cell apoptosis and Hashimoto thyroiditis. Following the death, we have the thyroiditis, which destroys thyroid, the thyrocyte, the thyroid cells, inducing hypothyroidism. So hypothyroidism is the latest stage of Hashimoto thyroiditis. On the other side, we have the TSH receptor antibodies, which stimulate or they may block thyroid and increases the secretion, the formation and the secretion of thyroid hormones, inducing hyperthyroidism. Or more rarely, they may block thyroid and induce atrophic thyroiditis. We said that we have the genetic factors and the environmental factors. And please look at the marked in red environmental factors: iodine intake, selenium, vitamin D, and the gut microbiota as main factors inducing Hashimoto thyroiditis. But we will talk a little bit about iodine, how iodine may interfere and induce autoimmune thyroiditis. We all know that iodine is absorbed from blood and is transported by iodine symporter, which is located at the basolateral membrane of thyrocyte. It is then going through the follicular cell into the follicle colloid by pedrin. It's a second transporter. Is oxidized in the follicular colloid. It is iodinated and the coupling with thyroglobulin, which is then coupled with iodotyrosines. They form thyroxine, which is by endocytosis and proteolysis secreted in the blood. Very important, the Wolff-Chaikoff effect. What is the Wolff-Chaikoff effect? If we have an excess of iodine, suddenly an excess, for example, when the cardiologist having a patient with atrial fibrillation, they give amiodarone, Cordarex, 1,000 of milligrams may enter the thyrocyte, and the TPO is blocked. Then we have a decrease, a sudden decrease in the secretion of thyroid hormones after 1-2 days. First we have a big release and then a decrease. But if it persists, if we continue to give, then we have this Chaikoff's effect. It is blocked. Iodine supporter is blocked. No iodine is coming into the cell. And this permits the thyrocyte to restore its action. We can have again thyroid hormone production. This is very important in thyroidology, the Wolff-Chaikoff's effect. A close relation exists between autoimmunity and autoantibodies. We have seen that thyroiditis is marked by the production of anti-TPO, antibodies against the thyroid peroxidase and anti-thyroglobulin. Despite this, some patients are persistently negative for disease-specific autoantibodies. We have thyroiditis with the so-called seronegative thyroiditis, no antibodies, but in the ultrasound, there is this inhomogeneous pattern. So the patient has an inflammation, but the antibodies in blood are negative. There are also situations that the autoantibodies are positive in healthy subjects, and differentiating also by the conditions. Latent autoimmunity, very low level of autoantibodies, and a very slow progression of disease. Preclinical autoimmunity, no symptoms, only positive antibodies, and postclinical autoimmunity when already the thyroid has been destroyed, and we have the final stage, hypothyroidism, at the various stages. The association of thyroiditis with iodine intake is here be seen in this paper by Lee, and you see that we have a subclinical hypothyroidism, a mild one, and you see the gender difference. according to iodine concentration in urine. And the highest the iodine concentration, the higher the incidence of subclinic hypothyroidism on the left, and the severe forms on the right. So there is a clear association between iodine excretion and autoimmune thyroiditis and subclinical hypothyroidism. Subclinical hypothyroidism is, let's say, the first or the second stage of the disease, when the TSH is increased, clearly increased the TSH, and thyroid hormones are normal. And then if it remains untreated, or if it is not, if we do not intervene, then it will follow the final stage, the overt or clinically overt hypothyroidism. And here it is also the presentation, the manifestation of disease, the mild and severe subclinic hypothyroidism according to age. You see well, the oldest people have higher incidence of various forms of subclinical hypothyroidism and also of overt hypothyroidism on the right hand. And here again, this is according to the antibodies. Another pathogenetic factor proposed by several authors, we also with Professor Biondi could show that leptin, which is involved in obesity and diabetes 2, might be a factor promoting autoimmune thyroiditis. How? By inducing inflammation. Inflammation is a very important factor, so that leptin, which you know that is regulates TRH because it is a regulator of a convertase, and TRH secretes TSH, TSH secretes, stimulates thyroid. So might be involved in the autopathogenesis of autoimmune thyroiditis. And then the second factor that I had marked is the selenium. And there are studies. I go a little bit more quickly here. In China, they have looked in regions with low selenium and high selenium intake, and they have seen that the regions with lower selenium intake had the highest incidence of all thyroid diseases. And they have classified the selenium according to quintiles. And the first quintile, it means below 50 micrograms a liter. You can here see the first that had the highest incidence of autoimmune thyroiditis. So selenium depletion, low selenium is a factor for inducing thyroiditis. And very recently, very interesting, that selenoprotein, which is a transporter of selenium, they have detected antibodies against the transporter of selenium. This is very interesting, and it's a fascinating story, showing that the transport of selenium might be disrupted, and this may have as may lead to decreased selenium absorption, and then resulting in decreased GPX, glutathione peroxidase activity, which is very important, is antioxidant. And also the other deiodinases, and the enzyme TPO, for example, is controlled by a selenoprotein, and it's a selenoprotein, and they are disrupted. It means that we have a high production of antibodies destroying the thyroid. And interesting here that autoimmune thyroiditis is above an umbrella which covers many diseases: allergic, inflammatory bowel diseases, celiac disease, depression, multiple sclerosis. All these diseases may result in autoimmune thyroiditis mediated by microbiome. If there is a dysbiosis, if our intestine does not properly work, if the intestine has inflammatory disease, then may promote thyroiditis. And here there is an animal study. They have induced a dysbiosis by hydrogen sulfide, and they have shown that those, excuse me, where were I? Yes. Okay. Yes, here that those mice, it was a mice study, and those mice who had Hashimoto thyroiditis and dysbiosis had a very disruptive thyroid, as you can see in the histology. Just very quickly now, vitamin D, you know that the vitamin D is the biosynthesis is stimulating by sunlight, and the active form 1.25 is not only the kidneys, but there is also in immune cells. So it may be involved in the pathogenesis of thyroiditis. Indeed, the antigen-presenting cells are stimulating the T lymphocytes, T-tolerance lymphocyte cells, which stimulate the monocytes to differentiate the dendritic cell and promote the T cell proliferation. The innate immunity, the adaptive immunity, we have a shift towards from T1 to T2, which may result in a decrease of T17, which are bad cells, which induce several inflammatory diseases, and increase the T regulatory cells, which are more protective. Coming to now so we have seen the various factors which are involved, the main factors which are involved in thyroiditis. And the Hashimoto thyroiditis, which are the symptoms? There are multiple, as you see from this table. It is variable. Any patient has his own, there is not homogeneous. There are variability also regarding the intensity of the symptoms. And we may have patients without clinical symptomatology. The treatment, as we know, it is monotherapy with levothyroxine, according to the guidelines of the European and the American Thyroid Association. But the question is when and whom to treat. If we detect a patient with subclinical hypothyroidism and autoimmune thyroiditis, should we treat him with levothyroxine? So let's look briefly at the second case. A 54-year-old female, mother of two, presented in the clinic complaining of loss of concentration, somehow it's a brain fog that we hear very much in the last time, of rather depressive mood, variable mood, but she has lost a close relative 3 months ago. So she's cold intolerant, no smoker, no other specific signs or symptoms in the clinical examination. Thyroid was not enlarged, has lobular structure by palpation, no nodule taskbar. It was normal weight, and the blood pressure 140 to 90 milligrams. So, what do you think? She has some symptoms which may be alienated with Hashimoto thyroiditis, as we saw in the previous tape. On the previous tape, would you ask for more laboratory testing? Of course, we have no. So we proceed, and TSH was 6, FT4 was normal, FT3 was also normal, TPO antibodies were negative, as well as TG antibodies. Would you treat this patient? Who will treat this patient with levothyroxine? 54 years old. Maybe you can ask some more. For example, would you ask how is the cholesterol and the lipid profile of this patient? It is correct. You are right. We have made a blood analysis. She had a slight anemia, hematocrit 36%, MCV, well, with microcytic anemia, a slight microcytic anemic patient. Vitamin D, B12, excuse me, was rather low, 236, normal levels 200 to 1,000 milligrams per deciliter. Total cholesterol high, LDL high, the ratio, borderline ratio HDL to LDL. The triglyceride was normal. Having this profile and having this clinical examination, who would treat this patient? Please come up and propose. Professor Akhimova, would you treat the patient?
Но учитывая, что это женщина, 54 года, учитывая, что у нее есть клиника и уровень ТТГ 6.
As this is the woman, clinics, TTG 6.1, we could have assigned her a small dose of thyroxine. But first we should have added B12 and anemia. We could have done it a bit earlier. So first iron, B12, then take a look later. How would thyrotropic hormone would change if it stays high? Then we could have added some small doses of thyroxine.
Your proposal, although the guidelines are rather ambivalent. I would like to present you the ETA guidelines for the management of subclinical hypothyroidism. I had the honor to be part of this task force 10 years ago. We have produced. The guidelines are still valid. And what do the guidelines say? First of all, regarding diagnosis and management of clinical hypothyroidism, according to age. This is very important, age of the patient. This is very important. And you see, let's take a patient below 70 years old. Our patient was 54. If the patient had or have a TSH below 10 and will look for hypothyroid symptoms. If he has no symptoms, we observe, we perform the thyroid function testing, and we recommend to see the patient 6 months later. If the patient has symptoms, we can start a trial of L-thyroxine, then assess the response to treatment by examining the TSH 6 or 8 weeks later. If the patient is above 70, then we are more, let's say, reluctant to treatment. And if we are more reluctant to treatment, we consider thyroxine only if clear symptomatic of hypothyroidism exists, or if the patient has a high vascular risk. So, these guidelines are well supported by this review by Bionti and Cooper, Endocrine Review 2008. And you see that the risk is increase in the in those who age 50 to 65. It is the dangerous decade. It is rather on the left. It's 50 to 60, 55 to 60, 5 years old. They have the highest risk, according to the many studies showing an increasing risk when the TSH is low. And the others, as age, the risk is reducing. So we must take into consideration the age of the patient and secondarily the TSH. So in our case, the patient was 54. He has a borderline lipid profile, which might increase his cardiovascular risk. And he had a symptomatic, which is okay, it's a little ambivalent. He had a mood swing, but he had also lost a relative, and was some tiredness. So it was, of course, it is not wrong to prescribe thyroxine for a short period. We'll see how he reacts. If he ameliorates his profile, the TSH is coming down, and then we will decide if we will continue with thyroxine or stop treatment. So coming to the end of my presentation, what can we have as a take-home message? So the Hashimoto's thyroiditis is on the rise on a global basis due to genetic, environmental, and personal way of life factors. Personal why? Because thyroiditis is more common in patients who are obese, patients who have high leptin levels, in those who have a diet who is not good, who has a lot of processed meat and processed food, a lot of white wheat bread, and few salads in their diet. So a diet which does not provide thyroid with all the necessary items to properly work. Iodine, vitamin A, vitamin B12, vitamin D. I went rather quickly, but vitamin D is very important to prevent thyroiditis. Vitamin D is very low in patients with autoimmune thyroiditis and also in inflammation. That's why we gave in all patients with COVID-19 high dose vitamin D. We talked about the polyglandular autoimmune syndrome, which is to be considered with when various symptoms, signs, autoimmune diseases are presented. We talk about the equilibrated nutrition, and at the end, treatment should consider age and gender. When treatment decision is made, levothyroxine monotherapy is the first choice, according to the present guidelines. I am coming to the end of this presentation. I would like to thank you very much for your patience and for being here so numerous with us today, and Rahmat. But
Thank you, Professor. Спасибо.
I have not finished yet. Thank you very much.
Okay.
Because I would like to present you and cordially invite you to Greece next year, as we have the honor to host the European Thyroid Association annual meeting in Athens in September. I'm chairing the meeting, and so you are very, very welcome to attend. And this is also a direct invitation to become members of the European Thyroid Association. There are, I think, one or two, if I'm not wrong, very few people, members from Uzbekistan, members of the ETA. Please come in and be members, be part of a huge, big global influence association. We are the second thyroid association in the world, together with the American Thyroid Association. We produce guidelines, we have very good educational programs, we have journals, so you can educate yourself and be part of a worldwide network. So now I'm really finished, and thank you once again very much.
Thank you, профессор. Я думаю, вопрос...
I think, well, we have the Q&A session. I think later we will summarize. But if you allow me, let me give a floor to Gulnara Nishanovna. Hyperthyreosis treatment among special groups of patients.
Подключите ему. Ага, speakerphone. А пока у нас есть время, да, я хочу сказать, у нас более 130 участников в зале и 51 участник подключились онлайн. Насколько это оказалось актуальным, видите? Так что надо расширять границы. Не проблема, не проблема. Мы не были в Греции.
No problem, we haven't been to Greece. Yes, it's not a problem, we haven't been to Greece. So yes, we would be happy to come. First of all, I would like to thank our dear professor. Excellent presentation there was. A lecture of both classical type, but at the same time, very high stake was set to our endocrinologists, so that we understand, yes, we do more diabetes and its deficit, but we do very little autoimmune diseases. And before that, professor was actually asking me what is the prevalence of autoimmune diseases, and it was hard for me to answer. I didn't have any data. And he said, if we're going to struggle with the iodine deficit, we will increase the number of autoimmune diseases. And actually, this conversation about the lack of selenium and vitamin D give us great opportunities to increase our research activities. We can apply for many grants for autoimmune conditions and accompanying diseases, and I think we are a lot of work to do. Thank you very much indeed for this high stake that you have set just now for our endocrinologists. I would like to start my lecture, Hyperthyreosis, Introduction and Purposes of Treatment among the Special Groups of Patients. As our professor has just said, he said that we need to pay attention. Yes, actually, I would put a stress on that. When exactly and what needs to be done, under which forms. Actually, hyperthyreosis is one of the most common endocrine dysfunctions in hidden form. I'm very sorry. It's present among from 4 to 20% of adult population. Higher concentration of TSH is more common among women and countries with the deficiency of iodine. Replacement therapy of thyroxine is recommended as lifelong treatment for all patients with hyperthyreosis with sustainable deficit of thyroid hormone. LT4 is one of the most applied drugs in the world, and the purpose of this replacement therapy among the patients to reach biochemical euthyreosis and also resolution of symptoms and hyperthyreosis indicators. We just spoke about recommendations of American European Association. This is the recommendation of American Association of dated 2014, which is ATA, which says recommended therapy of thyroid hormones must start as the initial, full, or partial replacement with the gradual increase of dosage under control of TSH. Regulation of dosage must be conducted under big changes in body weight, under growing age, under pregnancy, with the TSH control after 4 to 6 weeks after every change in the dosage. And another recommendation, when choosing the initial dose of L-tyrosine, we need to take into account the patient's weight, muscle mass of weight, pregnancy status, etiology of hypothyroidism, level of increase of TSH, age, total clinical context, including having cardio disease or presence cardio disease. Also, we need to take a look at the serum corresponding to the clinical case. Please make a photograph of this table. This is the excellent table, which also coming from ATA, which gives all the levels of dosage of thyroxine depending on the condition. Let's go through that. Adults with primary hypothyroidism, 1.6, 1.8 microgram per kilogram per day with the repressive therapy. Aged patients, 25 to 50 microgram per day with the gradual increase of dosage for 25-50 microgram per day every 3-4 weeks. Very aged patients, which are older than 70 years old. Take a look. Beginning of therapy and titration, the step of titration is 12.5 up to 25 microgram per day with gradual increase of dosage for 20.5, 25 microgram per day every 3 to 4 weeks. Patients with the ischemic heart disease, 12.5 microgram per day with the gradual increase of dosage by 12.5 microgram per day every 3-4 weeks. Pregnancy. We have very high birth rate actually in the country. Take a look. If a woman had hypothyroidism, increase of dosage by 30-50%, and she must inform her doctor if by specific weight from 2 to 4.4 microgram per kilogram per day. Inborn hypothyroidism, it depends on months. Newborn, at least 8-10 microgram per kilogram per day. First 6 months, from 6 to 10. After 6 months, like 6 to 12 months, 6-8 microgram per kilogram per day. From 1 to 5 years, 5 to 6 microgram. From 6 to 12 years, 4 to 5 microgram. Older than 12 years. And adults, 1 to 3 microgram. And of course, this is lifetime. If central hypothyroidism, 8-10 microgram per kilogram per day, and juvenile and adult central hypothyroidism, 1.3 microgram per kilogram per day. So what else is important? It is important to see the targeted level of hormones. We had change of data recently between European American associations, and look, before the pregnancy, actually, I'm puzzled with this. Before pregnancy, lower quartile of reference range, less than 1.2. Pregnancy first trimester, yes, we understand it must be less than 2 to 2.5. Children with inborn hypothyroidism must have less than 5, but even better if they have from 0.5 to 2, because there was special research made which said if we give this dosage of thyroxine that we have less than 2, the level of this thyrotropic hormone, the mental ability of this child would go to the normal with healthy children. Young patients from 1 to 2.5, patients of average age from 1.5 to 3, aged patients. If less than 65, they can have around 4.5 level TSH, from 60 to 70, more than 6, if 70 to 80 years old, up to 80 years, higher than 7, up to 8 level of TSH. So these are the targeted level of thyrotropic hormone, which we must achieve on the background of therapy with L-thyroxine. So we must not, at the age, people strongly reduce the level of thyrotropic hormone. If there's the cancer of thyroid gland, we reduce the level of TSH a lot, especially if this after the cancer, after the surgery, the level of TSH must be suppressed. But using the treatment of L-thyroxine, we need to know the side effects. So if you overdose the L-thyroxine level, we will have symptoms of thyrotoxicosis. We'll have fibrillation and increase of general cardiovascular events. If we have deficiency, it would be symptoms of hypothyrosis, increase of cholesterol or LDL, increase of body weight. And look here and there, both increase of risk of cardiovascular event and cardiac PF. American Association of 2014 talks about connection between atherosclerosis and heart disease, how they can influence the control of replacement therapy of L-thyroxine. We recommend to take into account the accompanying events like atherosclerosis, to put realistic goals of treatment and avoid acute diseases. How the L-thyroxine therapy among the aged patients with hypothyreosis must be controlled. Recommendation: the treatment must start from the small doses with gradual increase based on the indicators of the TSH serum. Must be acknowledged that higher threshold of serum TSH among the aged people older than 65 must be taken into account. So how the L-thyroxine is sucked in. We do that in order to explain the correct intake of this medicine. Intake of the oral goes through the digestion during first 90 minutes after the pill. Sucking in is not complete because 70–80% of the dosage is made. Decrease up to 40–80% could be observed during intake of food or drinks. That's why how to take L-thyroxine the right way, especially this is the recommendation. Look, as the simultaneous intake of food or drink can weaken L-thyroxine, it is recommended to take it either constantly or 60 minutes before the breakfast or before sleep, 3 or more hours after dinner for the optimized, sustainable sucking in. I should say that I'm meeting very surprised prescriptions, even from very high authority hospitals, and they say that patients must take L-thyroxine at 5 o'clock in the morning, and poor patients wake up to take it at 5 o'clock, and then they say we go to sleep. And I was shocked. It is not needed at all. Just it is enough. Just 1 hour before breakfast with good amount of water. That's pretty enough, I should say. So what else can influence gluten disease, atrophic gastritis, pylori infection, digestion infections, excessive bacterial growth, liver diseases, cirrhosis, obstructive disease, pancreatitis, and surgical interventions, eunostomia, and I can add what is metabolical surgery. You understand that they exclude from digestion if the patient had thyroxine. Under obesity, it could also be hyperthyrosis. And here we'll have reduced ability to suck in the L-thyroxine. What is the level TSH considered as the higher threshold of norm during the pregnancy? This has always been the subject of argument between our endocrinologists, especially during the pregnancy, because there were different criteria. So who paid attention to that in 2014? That's European Thyroid Association, and they produced these guidelines. The first trimester, 2.5 or less, second trimester, 3 and less, and for the third trimester, 3.5 or less. And then in 2017, they've published, American Association published guidelines, and they say for all trimesters, 4, but they specified, actually made a specification. First recommendation must be applied reference thresholds for TSH with concretizing the trimester as defined for populations with the optimal iodine consumption. Unfortunately, in Uzbekistan, we don't have this data. We still haven't understood what are the normal level of thyrotropic hormones if we have a heavy iodine deficit. We don't have this data. We don't have this level of T hormones. And the second recommendation, if there are specific thresholds by semesters not presented in the lab, the following reference thresholds are recommended. First trimester, less than 2.5. Second trimester, from 0.2 to 3. And second, from 0.3 to 3. And we also agreed with that, and our gynecologists and reproduction doctors are dealing with these levels of thyrotropic hormone. So what else? We are all struggling, if I can say, with the questions on subclinical hyperthyreosis. And take a look. We also have this recommendation from the American Association dated 2017, defining the TSH in groups of risk during the pregnancy and defining the anti-thyroxidase with the TSH level from 2.5 to 10. We calculate subclinical hyperthyreosis, not from 4 to 10, but from 2.5 to 10 during pregnancy. And what else? If the level of TSH from 0.1 to 2.5, then there is no need to supervise this pregnancy. But if the level of TSH in this gray zone, as we say, from 2.5 to 10, and with that antibodies are positive, there are two options. If from 2.5 to 4, please pay attention, could be L-thyroxine, not absolute. You see, if there are some symptoms of hyperthyreosis, clinics, yes or no. In this case, we can assign, we may not, if there are no symptoms. Second option, if the TSH from 4 to 10, and here, absolute recommendation in prescribing L-thyroxine. If there are no antibodies, but the level of TSH from 2 to 4, no need to assign to prescribe L-thyroxine. But if the antibodies are negative, but interval from 4 to 10, then again you can consider having clinics. And the last option, if the TSH higher than 10, absolute yes, prescribing thyroxine without any doubts. So why it is so important? take into account subclinical forms of hypothyroidism, as there are many gynecological complications which may end up and reflect onto a woman during the pregnancy. And this is the big list of these complications, including anemia, diabetes, low weight during birth, neuropsychological, and even cognitive complications after the birth. Look, many studies were made which showed having antibodies with L-peroxidase so this is the end of pregnancy, and hypothyrosis, which was with the mother, subclinical one, can reflect the cognitive functions of a child. It was also confirmed by some studies which showed neuropsychological complications of children, especially a woman with expressed hypothyrosis. Studies of 1969 showed that mother hypothyroidism is related with the decreased IQ level of the child. ATA in 2017 showed on diagnostics and thyroid gland diseases say that women were hypothyroidism who are planning the pregnancy before that, they need to take into account the TSH level and correct the dosage of LT4, giving the targeted value of TSH concentration less than 2.5. It's a strong recommendation. And recommendation 36, a woman with the hypothyroidism who take LT4 during the pregnancy must be definitely have to visit a doctor and have very thorough observation. Recommendation 15, there is no sufficient evidence data for and against that prescription of LT4 to women with euthyriosis and TBOAB can prevent premature birth. And there's no proof base that prescribing LT4 to women with euthyriosis and having the TBOAB can reduce risk of end of pregnancy. But this could be a small initial dose from 25 to 50 microgram. And women with subclinical hypothyrosis who are planning to have echo or ICSI, it is recommended to have replacement therapy of L-thyroxine. The purpose of treatment is TSH less than 2.5. If the thyroid gland function must be evaluated before or after 1 or 2 weeks after controlled hyperstimulation. Of ovary, result assessment of hormonal research during hyperstimulation could be very difficult for interpretation. All pregnant women must take about 250 microgram of iodine per day. To reach total annual dosage, strategy could change depending on the country of residence. And also in Uzbekistan, it is recommended 250 microgram of iodine for pregnant women. Also, ATA in 2017 made recommendations after the childbirth. The LT4 dosage must be reduced to the level which was taken before the pregnancy, and the control definition of TSH must be taken about 6 weeks after the birth. Yes. So, as the conclusion, to see the analysis of thyroid gland function among pregnant women, we must apply a reference threshold. Women with the TSH level above 10 must take treatment of LT4 during the pregnancy. Women with hyperthyreosis, the level of LT4 must be increased comparing with the early dose before the inception, starting from the very early stage of the period. And the hidden hyperthyreosis associated with the unpleasant result of pregnancy, including neurocognitive deficit of the child. So recently we have new recommendations of European Association dated 2021 concerning the thyroid disorders prior and during assisted reproduction. And here again I recommend you to make a photograph of this slide to be at least on level 2021. Please take a look at that. So we are taking women who go to reproductologist having different level, and we call them subfertile women. So we have the TSH tests, and we also antibodies OAB. If TSH higher than 4, if they take L-tyrosine, the dose correction 4 weeks before the ovary stimulation. And we must start tyrosine and control of thyropic hormone before ovary stimulation. If the level from 2.5 to 4, we define antibodies. If positive, again, we assign tyrosine and we control TSH before the ovary stimulation. If the antibodies are negative, control of thyrotropic hormone after the stimulation, ovary stimulation, if they take thyroxine. Similar recommendation during the TSH level from 0.3 to 2.5. Control TSH after the ovary stimulation if women take L-tyrosine. If the TSH less than 0.3, we need to make a test for free T3 and free T4. If it's a norm, observation. If higher level or on the contrary lower level, then we need to postpone this manipulation, the additional reproductive technologies, and make treatment of this endocrine disease. Shortly, we recommend all women who address for medical assistance about sterility or non-fertility must make observation for TSH and TBOAB. The test must be made accordance with the local protocols. So we assume that subfertile women with the TSH level higher than 2.5 without higher level of TBOAB, we need to make observation having higher level of OAB and TSH if it was not done in the primary observation. So we don't recommend to make systematic screening of the thyroid gland diseases among men from subfertile pairs. So we don't recommend to make screening of all non-fertile men and their relatives for the thyroid gland cancer. We recommend to women who are prepared for inception who must have ablation dose of radioactive iodine 131. Wait at least 120 days before starting the inception or sperm for echo or ICSI. First they take the dosage of radioactive iodine, and then after that they prepare for inception. We don't recommend to postpone the treatment with iodine-131 under the thyroid gland cancer for the reasons related to fertility. However, it is recommended that fertility or family planning issues would be discussed before the beginning of treatment with iodine-131, having the need to input several dosages. If the dosage is very high, then it is better to offer a man to give the sperm for freezing into sperm bank. We recommend not to postpone treatment of the thyroid gland treatment with iodine-131 on the reason related to fertility. However, the women older than 35 must be informed about the impact of iodine-131 on the level of birth. We propose these women as the preference method during the additional fertile technologies. We recommend to immediately start treatment of LT4 of women in case of vivid, obvious dysfunction of thyroid gland. We also recommend treatment women with LT4 and hormone IT and TSH more than 4. We also recommend treatment of LT4 to women without IT and order. We don't recommend to treat euthyroidic women without IT with the overstimulation. We recommend to check the TSH level after the overstimulation in case of pregnancy during the second or confirming measurement of women with AIT having LT4 or after the inception of LT4. We don't recommend monitoring of TSH after the overstimulation of our thyroidic women without AIT if they don't take LT4. And we also propose that our thyroidic women with AIT during echo don't have systematic treatment of LT4. I'm done. Thank you very much for your attention. Thank you very much, Gulnara Shanovna. If I may, I would summarize. I would like to summarize and say ATA and European Association as well both provide the recommendations for the zones with the iodine support and iodine provision. But we must not forget that so far we do have very heavy iodine deficit. That's why these recommendations of TSH less than half, we must have always with us. Given iodine deficit, we must very thoroughly, women especially pregnant women or before pregnancy or those who are preparing to be pregnant, we must observe them very thoroughly and if needed, bring up to the level of TSH before 2.5. Thank you very much for your attention. Gulnara Nishanovna, thank you very much. You are very precise in your recommendations. While people are preparing the questions, probably you have to put your presentations to the website of your Center for Endocrinology so that people would be able to apply all these recommendations. Or write the guidelines, national guidelines. Yes, indeed. If you allow us, we can put this presentation to the website with your permission, of course, and people provided the methodological recommendations because it's not just for endocrinologists. All people can use this information, especially those who are dealing with reproductology. And as to lecturers spoke too quickly, we can go to Q&A session. We have some questions in writing. Maybe some other people are preparing their questions, so they didn't write the person to whom the question is made. Shall we prescribe iodine during autoimmune with the normal level of TSH?
female patients, if they are pregnant, of course, we must look to have a sufficient iodine intake. We can provide iodine in tablets or multivitamins containing iodine. This is very important, particularly in areas where there is an iodine deficiency. The most important is to have sufficient iodine intake in the region, and then individual to look at our patients, that pregnant patients or patients who are in preparing the pregnancy. If they are subfertile, then we can maybe add various nutrients, including, for example, myo-inositol, including selenium, vitamin D, and iodine. You can ask me how much iodine, Professor Achimova. I think that it has been proposed, it has been suggested that those are 150. But it is safe to go at least up to 300 micrograms. Iodine is not toxic up to a level of 500, but it is better to have a dose close to between 150 and 300 micrograms a day.
Every day.
Every day, yes, of course.
Thank you. Ну, я думаю, в зале, если кто задавал...
I think there are people in the room. If you are happy with the answer, got the answer. Does it mean the dosage of iodine to develop the autoimmune thyroiditis? I am reading what is written to Professor Duntas.
Can you please repeat the question?
Doesn't mean the dosage of iodine intake. I'm reading what is written, come on. Then be specific in your question. If you can repeat it.
If there is a genetic predisposition, iodine intake higher than the proposed daily intake may induce thyroiditis. We have seen in many populations, may trigger, this is the right word, trigger thyroiditis. Only those who have the susceptibility. Susceptibility is a nice word defining the predisposition. And if you have a high 200, 300 micrograms a day over a certain period of time, we have seen the mechanism via the Wolff-Chaikoff effect. We have seen the mechanism of iodine excess. So it depends on individual basis. If there is a continuous high increase in iodine and the patient has these genes which are involved in thyroiditis, that they may trigger via stimulation of T lymphocytes an auto-reaction, that it means that the patient loses the self-tolerance. Self-tolerance is that we do not know if the organism recognizes something foreigner or something from itself. And so that the T lymphocytes may induce an auto-reaction producing antibodies, which are mainly against two proteins, thyroperoxidase and thyroglobulin, which are the most common antigens of thyroid. So having an increased iodine intake, and when I say increase above at least 150, over a certain period of time, and if you have the susceptibility, you can get thyroiditis. which may in the beginning be light form, just you detect thyroid antibodies without any clinical symptomatology, which as time goes by, this may be worse. And we have then a latent or a preclinical form, which may, over the years, particularly we have stress or other factors, we have a deficiency in vitamin D, can be progressed to an open hypothyroidism. There has been a paper by Mark van der Pump in clinical endocrinology. It goes by the end or mid-end of the 90s, showing that TSH threshold is 2.5. If the patient has antibodies and the TSH 2.5, you must better start treatment because this patient had 5% probability to develop hypothyroidism in the next 5 years. So in order to prevent this, you can start treating. Repeat, that a patient with a TSH 2.5, anti-TPO antibodies positive, we have discussed, according to guidelines, depending also on age, giving or not giving thyroxine. If he has 2.5, the probability is 5% to develop, to go to hypothyroidism. So it's better to start the treatment. I do not know if I have satisfactorily replied to the question.
Спасибо.
Thank you. For me, 3 questions. Interesting. Do we need to prescribe iodide natrium to patients that take LT4? If the patients take LT4, they don't have to take the iodine-related drugs. Exception is pregnancy. If the patient takes LT4 with hypothyroidism, probably not. But if she has goiter, then yes.
Under thyroxine should not take iodine in addition to take some iodine. Why not?
Ну, учитывая
Well, given our iodine deficit, I don't know really. I guess no need.
Because of iodine deficiency, to also supplement some iodine, I repeat, in pregnancy, particularly in the first trimester. Take care. If you give 100 microgram L-thyroxine to these women, you supply them with 62 micrograms iodine, because T4, why we say L-thyroxine? T4, because it has 4 atoms of iodine. So we give them, exactly, we supply iodine. But if you give a little bit more, doesn't matter. Maybe it is better to supply at least 100 micrograms in addition to LT4. Not as a tablet. First of all, the diet should be rich in iodine. The diet is very important. And then, if the patient does not comply, for example, if the patient does not eat fish or they do not use iodized salt in the management, so we can also give some iodine in pregnancy. Why not? Why not?
Сразу, Гульнар Ильич, в продолжение вопроса.
To continue the question, Professor, they also say, do you need to prescribe selenum to those patients that have a deficient function of thyroid gland if we don't live in selen deficit region?
Thank you very much, whom have made this question. I'm a big fan of selenium. Selenium and iodine are the pillars for thyroid function. If we have selenium deficiency, thyroid has problems. And this study by Wu in China has clearly demonstrated this. Selen in patients with autoimmune thyroiditis is very often low. And so prescribe selenium. We prescribe selenium by measuring selenium, or even better, the selenoprotein P, which is a protein, which is a transporter, which is a depot protein for selenium. And selenium, coupled with iodine is optimal for thyroid function. If the region, and I suspect that here the center of the country is a borderline selenium deficiency, because selenium deficiency goes together with iodine deficiency. Where there is a big iodine deficiency, there is also a selenium deficiency. So in these cases, you must think, first of all, in the cheapest way, how to provide selenium. And selenium is with nutrients, for example, Brazilian nuts. Brazilian nuts is the nutrient with the highest content in selenium. You can do the best for your patients, advising to eat a lot of Brazilian nuts. Not a lot, 4 every day, up to 4. Because selenium, Brazilian nuts have a high content also in cyanide. The patients can have awful headache if they eat 10, 15, etc. So take care. There are some studies showing that selenium may reduce the intensity of thyroiditis. And we have made a study in Greece. Greece is a borderline, depending on the region, borderline selenium deficiency. We have made a study with selenomethionine, so with organic selenium, and the results were very encouraging. But we cannot provide selenium to everybody without knowing the levels of selenium in blood. Thank you for the question, because selenium is one of my favorite topics.
Следующий вопрос. При узловом зобе с нормальными показателями ТТГ нужно ли назначать йод-препарат?
Under the it's about goiter. Sorry, I missed it. With the normal indicators of TSH, shall we assign iodine or LT4? No, no need. No need. If your TSH level in the normal threshold up to 4, it's okay. Why iodine? No need. Thyroxine? No need. If then autoimmune worsening towards hyperthyreosis, yes, but I need to say not up to 4, but up to 2.5. My colleague just said no, up to 2.5. If higher than 2.5, then he said just we need to start prescribing L-thyroxine. But you see, this person is talking from the perspectives of Europe and United States. We have different. We need to make observations. We must not say for sure. Firuza is laughing. It is not funny because we don't have the data. I don't know if we are selen deficit or not. I just looked at the Brazilian nut. And next to it, they say pistachio nuts. These are also nuts with the selen content. Any nuts. Any nuts. Peas, broccoli, they have selen. even pistachio. I understand pistachio are very local nuts. We eat them commonly. They're very common here. That's why I have no idea if we have a deficit or not. That's why I was preparing a question.
Yes, and the advantage is with pistachio that you can eat a lot because there is no restriction as with Brazilian nuts. But it is important to, of course, Professor Rahimova is moving because she's thinking maybe on the calories, etc. But you can eat much more pistachio than Brazilian nuts. And there are, of course, broccoli, there are tuna, there are the fish, salmon, containing selenium. Yes, selenium, vitamin D, do not forget to consider these both nutrients in patients with thyroiditis. I think that's what I would like to ask.
Понятно.
Я сразу продолжу.
Let me continue. Can we give iodine to pregnant people with the TSH with anamnesis? There are very many points, but generally, no. So last question, oh, maybe not last, I don't know. Under hypothyreosis and higher level of antibodies to peroxidase among the feeding woman using L-thyroxine, would it impact the child? Answer, no. On the contrary, the child will get more T4 and be smarter. Excellent. And the last, wait, one more. What are the highest allowable dosage of L-thyroxine? No, there are none. We just said, depending on the body weight. I had a patient myself, actually a long time ago, who had 300 microgram. If she was reducing the dosage, she was going into deep hypothyreosis. There are no limits. Well, there was no 400, but 3 microgram. I myself had such a patient who got thyroxine. Right?
You know what happens? That some patients that they need a lot of thyroxine, they may have mutations in the deiodinase, the type 1 or type 2 deiodinase, which convert thyroxine to T3. And if there are mutations, they do not have enough sufficient production of T3, leading to symptomatology, which, you see the TSH is okay at the desired level, but the patient does not feel well. And you go and you give more thyroxine. You do not adjust the problem, because these patients, it's about 20% of the patients, they may need T3 combined with T4. The problem is that we do not have T3 in very small amounts, so to be combined with, for example, 100 micrograms of thyroxine, because it is the ratio. If you give a lot of T3, the patient can have side effects.
Правильно.
Correct. Actually, we have a big need in such combined therapy. We have many patients who need that. And actually, a question to the company. They have the combined product, but they don't supply us. But we do have patients who need that. Look, very interesting question. Could you please have the final point in the question of influence of antibodies and TB be higher, but autoimmune process, so far we cannot stop. We can only corrigate the level of thyrotropic hormone, less than 2.5, as it was said before. And then subfertile woman possibly become pregnant. I have a question. please.
Here is something to discuss. TPO antibodies. We do not know exactly their function. There is a high probability that they may disrupt the placenta. So it is right to try to reduce the intensity. How will be the pregnancy, how will be my delivery. So you can talk to them, try to persuade them to stay calm, to have some gymnastics, to walk. Stress management, very important. Then nutrition, we have seen. So they must look at the diet and maybe provide, give vitamin D or selenium per tablets or by nutrition so that we can decrease this effect. Thank you very much.
Еще
Antibody pictures. Yes, I think he just answered this question. Professor has just answered unanswered question.
микрофон.
Yes, I know. Well, a colleague asked me if we can use plasmapheresis to treat patients with autoimmune thyroid disease. I will spontaneously say no, because, you know, it is a chronic disease. If, let's say that there is some very severe autoimmune thyroiditis with encephalitis, you know, there are some rare cases that anti-TPO very high may induce this thyroid madness. Okay, and you think to make a plasmapheresis. In 2-3 weeks, the situation will be the same. So, and of course, I wouldn't advise to start plasmapheresis because of some side effects and, of course, because of the cost. It's a very expensive procedure. But it is an interesting thought to use plasmapheresis. I think there have been 1 or 2 reports, but I don't think that it is a common procedure.
Спасибо. Thank you.
Можно мне?
Thank you. I have a question to the first lecture. There was a slide in your presentation about severeness of subclinical hypothyreosis. Light form, heavy form, and obvious subclinical hypothyreosis. And what are TSH criteria to have this TSH criteria under light, heavy, and vivid or severe?
Light is or mild hypothyroidism. It is 4.5 to 7. 7 to 10 is the moderate, and above 10 in patients below up to 65 years. Above 10 is overt hypothyroidism. This range is modifying by age. If we have above 70, for example, the study from Newcastle, 85 plus, the normal rates according to 2.5 and 9.5 per child of TSH is different. Then we have up to 7, very mild disease. We do not intervene in patients above 20, older than 80 and 85 years old. Then we have 7 to 10, 7 to 12, and the recommendation to treat them when the TSH is above 20. We can discuss if it is okay or not. It depends on many other regarding his cardiovascular risk, regarding his ability, etc. If we will treat him, but so are the guidelines. Okay. So.
Спасибо.
Thank you. I would like to say we have many more questions among online participants, and I think we will keep them for the second part. Right? Okay? Professor, okay? I'm using the opportunity of me being chairman. Let me ask you two questions. First of all, thank you very much for your presentation. It's been very interesting. COVID-19, while it's existing in different forms of manifestation, how big is a reason provoking these autoimmune diseases? Because then you had the second time the slide where you put this red removing infection, but my question was provoking by COVID-19. And the second question, let me immediately ask to the girls' question. There was a different slide, 3 diagrams. Hyperthyreosis among adults is increasing with age, hyperthyroid condition. And I think dementia, is it related to that? Are there any research with age related? Because we have put the age threshold 70, 80 years according to national program. How important it would be for us to influence that, not only to increase the age life, but also the mental function of aged people, because we can have a nation who live more than 80 years, but mental function could be so reduced. That would be a big question.
Reply with one word, FT4. There has been a study from Rotterdam. In Rotterdam, they have a big consortium there, and they look at the various ages, and they have found that dementia is associated with the highest FT4 levels within the normal range. So FT4 close to the upper level is associated with dementia in older people, people above 65. We have started looking at people above 80, 85, because there are many people now that they live longer. They live till 100, even longer. So this is a smaller part, but normally the many people, 65 to, let's say, 80, FT4 should be medium, not in the upper level. It means that the TSH should be at the highest normal level. If the TSH is very low, within the normal range, low, let's say 0.4, it is on the borderline to subclinical hyperthyroidism. Then automatically the FT4, because there is a linear association, will be at the uppest level. And this is bad for people over 60, 65 years old. It is maybe good for younger people, but not for them above 60 years old. This is associated with dementia. This is associated with increased cardiovascular risk. COVID, yes. COVID is very interesting. Why? Because this SARS-CoV-19 virus we know that is entering via receptor of angiotensin converting enzyme. Converting enzyme. This receptor, look at it. It is very densely present where? In thyroid. It is more intensively presented on thyroid than on the lungs, for example. Intestine, lungs, they have the highest density of ACE receptors. So we have many patients having COVID who developed a special form of subacute thyroiditis, marked by pain, fever, very low TSH, normal T4, and low T3, and normal borderline increase T4. It means that this is an infection which targets the hypothalamus, hypophysis, thyroid. And the conversion is disrupted. We have an increased RT3 production, and not T3. We have a production of the inert T3, reverse T3, and low T3. But it is not the usual low T3 symptom. It is marked by normal T4. And sometimes, if the T4 is also low, this is a very bad indicator for the outcome of disease. Then the patients, probably they will die if they have low T4, low T3, and TSH is low. Can you understand that TSH is low, we expect a very high T4, but it is not the case. T4 is borderline, and T3 is very low. Because the conversion disrupted, the TSH mechanism, maybe it is a central effect on the hypophysis, which is reflected in the thyroid. Exactly. It is very peculiar situation. And there are many patients, maybe some, let's say, lighter cases, but many with severe, serious disease, which persists for 4 to 6 weeks. And they're getting better if they survive the virus.
Thank you. Спасибо.
Thank you. Right, thank you. Now we have 15-minute short coffee break. Let me explain why. You must get connected online with the next lecturer, Ekaterina Troshina, now 7:16. Sorry, 5:16. We get back at 5:30 in order to have coffee break. We will have a very light coffee break because we'll have a very intensive dinner. So 15-minute coffee break. That will be even more interesting.
So thank you, Professor.
the strongest people without the iodine deficit, those who are eager for knowledge. The rest will bring up here. So colleagues, let's continue here. Technical service would suggest us they have a connection. Ekaterina Troshina, our professor, close friend. Our subject of presentation is replacement therapy of L-thyroxine, specifics of application of patients with cardiovascular risk. I think this is very interesting as well. Now we have a big growth of cardiological pathology, and more I am convinced that cardiological problems, often the prevention starts from endocrinologists, diabetologists. And we looked at the first academy, and now we are seeing as well that cardiologists work with cardiosurgeons, thyroid gland, to decrease the patients for us. Are you ready? Okay. Please. Ekaterina Anatolievna, the floor is yours. I'm sorry, the sound does not come to my ears. We need to tell the technicians. Just a second. I will tell the technicians that I don't hear anything.
Заболеваниями щитовидной железы. Я очень рада видеть.
All right. I'm happy to see you, dear Firuz Fuzgulaevich, dear Gulnora Nishonova, and of course I'm happy to welcome Professor Leonidas Duntas, with whom we are linked by very long-term friendship and cooperation with our National Medical Research Center of Endocrinology in the area of thyroid gland pathologies. But dear colleagues, today we would like to discuss with you, as I said before, the whole range of issues, and many of them were touched upon excellent presentations of my colleagues. My job is to put stress the replacement therapy with patients with cardiovascular risks. Looks what could be more simple than hyperthyreosis, and we've managed to diagnose it well, to treat it well, but even in this context, differentiated diagnostics of different diseases of thyroid gland, which could be going along with higher level of thyrotropic hormone, mean a lot, because if we in our clinical practice will not pay attention to nuances related to different conditions led to high level of thyrotropic hormone, we can go by a false path, and we can assign or not prescribe therapy without any reasons. That's why let me start my presentation from showing this slide, which shows very vividly this polymorphism, breaking the function of thyroid gland under different clinical situations. And if the situation of manifested hyperthyreosis are well understood by us, then subclinical hyperthyreosis is the condition which already requires differentiated diagnostics with a number of other diseases and conditions. The same is relevant to a situation when we see higher levels of thyroid hormones and higher level of thyroid hormone. And here we need to pay attention to the whole range of problems which lead these results of lab analysis. And getting back to classical hyperthyreosis, of course, the lab diagnostics today allows to put this diagnosis pretty quickly. We know well under which figures of thyrotropic hormone and under which figures of free hormone fractions of thyroid gland we say either about manifested or subclinical versions of this disease. Of course, hyperthyreosis has its own peculiarities, its own specifics in the context of changing in the lab analysis that we prescribe to our patient in a number of instrumental observations and researches. Normally for hyperthyreosis, it is specific to have violation of lipid exchange, and for hyperthyreosis also electrocardiogram changes, and we would remember these total trends, general trends, because then our whole conversation would be built around applicable to cordial problems, impact of hyperthyreosis onto heart, and also we will say how to treat hyperthyreosis among those people which have it in comorbid state, and the cardiovascular diseases. If you pay attention, dear colleagues, that hyperthyreosis is a very common pathology, and today it was not even once in my colleagues' presentations. They mentioned about it. They mentioned how often we come across subclinical violation of the thyroid gland function. In any case, hyperthyroidosis is related to development of many metabolical diseases. And just take a look at this slide. If we close the word hyperthyroidism and we read insulin resistance, hypercoagulation, dyslipidemia, hypermostinemia, increase of C-reactive protein, we will think about the whole pool of metabolic changes that we often see of patients with heart disease. Hyperthyreosis, if we see it with the specific patient, would always bring this negative metabolic impact into health of our patient. Even back in 1918, Mr. Zondak firstly described the syndrome of myxomatosic heart. And take a look at even back at ECG, back then paid attention to have bradycardia, low voltage of teeth, negative T-tooth. We can see cardiomegalia and pericardic breakdown. If you take a look at these components, a syndrome of myxomatosic heart, if we imagine that we are not talking about hyperthyroidism, and the question we can ask, what disease has specific changes of this type, we can say for pericardiacs, and see how important in the cardiological experience coming across patients that have such changes, not to forget that they could be under non-compensated long-time hyperthyroidism. Indeed, hyperthyroidism has its own cardiological masks. Could be hypertension, could be dyslipidemic and hydropericardics. All of that we must keep in mind. Totally diametrical opposite dysfunctions of hemodynamics could be observed under thyrotoxicosis, which is opposite to hyperthyroidism. And under hyperthyroidism, reducing the myocardic function, minute and systolytical volume of blood, amount of circulated blood, and decrease the speed of blood flow would be the foundation of maintaining all the myocardic problems and all the problems related with arterial pressure, which would be then strengthened in the human body and impacting his or her health condition. Indeed, hyperthyroidism provides long-term, non-compensated substantial role on developing the development of myocardial dystrophies and chronic heart diseases having myocardial dystrophy. Decrease the level of exchange processes in myocard itself, decreasing the absorption of oxygen, increasing of penetrability of vessels, iodine disbalance, protein deficit. These are all ways of development the myocardic dystrophy, and then myocardic dystrophy would be clinically manifested in more pains in heart, chest, equivalent to stenocardia or development of stenocardia at this patient, and of course arrhythmia, sinuside, bradycardia, blockade, and AV blockade. All the cardiological communities with large authorities and respect who dedicate their consensuses and guidelines to heart diseases take into account this reason, metabolical dysfunctions. And the first place among these dysfunctions in terms of heart disease, hormonal, and with that, thyroid gland diseases. It's also important because below we will say how hypothyroidism impacts heart functions, diastolical in particular. So hormone deficit in thyroid gland and systolical heart function. Pay attention that under heavy, non-compensated hypothyroidism, the heart output would be always decreased. It would be decreased substantially by 30–40%. The patients with clinical hypothyrosis would go down, but the replacement therapy with L-tyrosine would improve the condition. Systolic heart function and its decrease are the basis in chronic heart dysfunction. You see systolic function is down, vascular resistance, hypertension, arterial hypertension, arterial dysfunction. These are the main positions of blood circulation dysfunctions. And pericardial factors would belong to patient with non-compensated hyperperiosis. Also lack of hormones in thyroid gland, even at the early stage, at the subclinical hypothyroidism, already would manifest among the patients to decrease the level of endothelial vasodilatation, resistance of vessels, pre-heart natriuretic peptide, and higher sensitivity of arterial walls to vasoconstrictive and damaging action of catecholamines. It would play a role in creating the problems, cardiovascular problems. So thyroid, lack of thyroids or would be a risk in cardiovascular diseases. I must talk a few words about such thing as vascular rigidity. So far, all the major cardiological associations take into account this factor as the basis in terms of early vascular aging. Just look at it. What is it? What are the criteria we have to this phenomenon? And you see that the speed of pulse wave, which is the marker of damaging the vascular wall, is the office indicator of arterial rigidity. So arterial hypertension is associated with progressive increase of rigidity of arteries and could be spoken as the early vascular aging. What the hypothyrosis is dealing with that? Let's remember that thyroxine hormones of the thyroid gland play the main role in regulating biosynthesis and cholesterol synthesis. If you take a look at the left part of this slide, we see that practically all key phases of biosynthesis and exchange processes of cholesterol are regulated by the hormone of thyroid gland, thyroxine. We understand that if the thyroid gland hormones are not enough, all the processes would go in a totally opposite direction, bringing to development of the strong dyslipidemia of the specific person. That's why practically all publications and papers and consensus reflect that the thyroid gland function, increasing the level of low-density lipoproteins or LDL could be normal clinical practice to exclude hyperthyroidism, to exclude hypercholesterolemia, and treat it, compensate it in order to normalize the indicators of lipid exchange of a specific patient, playing the key role in developing atherosclerosis and ischemic heart disease. Together with cardiologists, we looked at the study which was aiming to define the daily indicators of rigidity of the vascular wall. This group of patients, which was presented by comorbid patients having essential arterial hypertension, who have all the components of metabolic syndrome and non-compensated hyperthyrosis, they were manifesting the most negative picture from indicators of arterial rigidity. That's why these patients, this phenomena of vascular aging is obvious. So this impacts the complications onto patients with cardiovascular pathology, and hyperthyrosis brings its substantial input in forming this vascular rigidity. You see this subclinical form, stiffness, it impacts its indicators, and during the conditions of heart would go down, even change of hormones of the thyroid gland. Arterial hypertension, which is associated with hyperthyrosis or caused by non-compensated hyperthyrosis, would accelerate progressive diffuse dysfunction from capillaries to main vessels and bring, along many other problems, violation of diastolic function of myocardium. What is the basis of developing of diastolic dysfunction of heart during the hyperthyrosis? Insufficient input of calcium into cells. This is a key things that regulate softening, relaxation on the opposite, the heart. This is the basis of creating the diastolic dysfunction of heart and the increase of diastolic blood pressure at the end. All of that could be prevented, it could be corrected if we treat hyperthyrosis. Total rules of replacement therapy by L-thyroxine. You all know this, dear colleagues, but as we have TIREO Academy today, we are going to repeat that. It's not bad to remember something. During the treatment of any patient with hyperthyrosis, we'll start from small doses of L-thyroxine. We will not going to use the combined therapy of L-thyroxine, L-triothyronine. We will correct the dosage that we initially prescribed after 6-8 weeks. If we have a patient with hyperthyrosis and existing ischemic heart disease. we see at the TSH level. If it's higher than the targeted one, and we'll talk later about the targeted level a bit later, and we might perform a whole pool of medical manipulations for these patients because prescribing of L-tyrosine in the adequate dosage without correcting the cardiac pathology may worsen cardiac pathology, and we might remember about that. What we expect the effects from this L-tyrosine. So we expect improving the myocardial function, improving the diastolic and systolic function of the left ventricular, improving the endothelialic function. These are effects of treatment with L-tyrosine. If everything is so good, why so many people who live in the world have insufficient level or dosage of L-tyrosine? Why so many people who live in the world have too excessive levels of L-tyrosine, which could worsen the conditions of cardiovascular diseases? Why? Because clinicists always ask questions which will make them doubt about something. What dosage of L-tyrosine could be prescribed to people with hyperthyrosis or cardiovascular diseases? Do they need to treat subclinical hyperthyrosis? Shall it be treated of patients with ischemic heart disease or aged patients, whether L-tyrosine therapy worsen cardiological problems, or maybe treating without thinking? And then there's a question whether this treatment might lead these to side effects, especially from heart, and so on and so forth. I think everybody, dear colleagues, we're asking ourselves these questions many times, trying to find answers, because we treat patients and trying to have individual approach, select dosage, we observe and monitor and control, but we must be focusing on generally accepted points which would help us to provide adequate medical help to our patients. We do remember that levothyroxine by itself has very narrow therapeutical range. We do remember that. That's why any step in a dosage would lead to quite substantial change in the level of tiotropic hormone, and monitoring of a patient condition is definitely needed. I'm talking about the narrow therapeutical range. We need to know about that. That's why when we talk about the early stage of replacement therapy during the hypothyroidism, for patients who are not aged yet, or who are not comorbid, but these are patients younger than 55 up to 60 years. The dosage of L-tyrosine would be made based on 1.6, 1.8 microgram per 1 kilogram of body weight. Initial dosage would be not small because there are no big risks here, would be different of people with cardiac pathology and patients older than 60 years. And here on the slide we see the early dosage of L-tyrosine, which would be calculated based on 0.9 microgram per kilo of weight. And we will tether dosage over the prolonged time. We'll start from 12.5 up to 25 micrograms per day. And of course, during the cardiac pathology, we will make a step back towards decreased dosage and making observation with the patient. It is allowed the level of this hormone with patients not exceeding values specific for subclinical hyperthyreosis, which means not more than 10. And the period of selecting the optimal dosage could reach quite lengthy time, up to 6 months. In these situations, our principle is not to hurry in order not to damage, choosing the tactic under subclinical hyperthyreosis. So here we are starting to think every time. And actually, this weight, we need to put the arguments yes and no. Treat or not treat? Do we need to treat or not to treat? How to treat? When do we move towards observation in general? Probably when we have a person who is older than 65 years, when a person has a normal lipidic profile, when the level of hormone is, TSH less than 7, with no cardiovascular diseases, with no positive antibodies to the thyroid tissues, when there's no increase dynamics of the hormone. We remember during the level of TSH, 3-6 month observation before we make any steps about therapy. When we treat, opposite arguments towards treatment. You see on a slide when and how, and among the people that have dysfunction of lipid exchange, they do have cardiovascular diseases, and who are younger than 65, and who can have symptoms of hyperthyreosis, increase antibodies to thyroid gland tissues. But dyslipidemia, level of TSH 7 to 10. These are arguments for treatment. Later we'll look at the algorithms proposed by our foreign colleagues in more details about these situations. Let's take a look, and once again let's discuss them. But at the very start, when we meet our patients, we need to go either immediate therapy or just dynamic observation and monitoring. So when we go for treatment, please pay attention that clinical manifestations of subclinical hyperthyreosis exist. They exist despite what we call subclinical lab phenomena. However, we all perfectly remember a Rotterdam study, which more than 20 years ago was made, but it was so brightly manifested the fact that subclinical hyperthyreosis is such independent risk factor of cardiovascular diseases, such smoking, dyslipidemia, and results of this study are quoted even today. And dyslipidemia itself, with higher level of androgenicity, higher risks of atherosclerosis and heart attack, was shown in Rotterdam research, which included patients with subclinical hyperthyreosis. This is important because we are talking about cardiovascular problems. We are talking about the prevention of cardiovascular problems. The dyslipidemia factor must be eliminated, especially if it is linked with regulated situation. But hyperthyreosis, in particular subclinical one, is a situation absolutely manageable. Cardiological arguments towards treating subclinical hyperthyreosis: improving lipid exchange, improving head of diastolic arterial pressure, and endothelia-dependent vasodilatation. Prescribing of replacement therapy by levothyroxine is okay under subclinical hyperthyreosis, and TSH under 5 and 10. Today we see very indicative publications and researches about correlation between sensitivity to thyroid hormone sensitivity and dyslipidemia risk in CHD patients. And one of such researchers, which included a lot of participants with dyslipidemia, identified among a lot of people connection between the hormone sensitivity and dyslipidemia risk. It was statistically valid. It did not depend on gender, AD pressure, age, glucose level, etc. Very strong connection between lipid exchange and thyroid gland hormones. That's why replacement therapy of hyperthyreosis by levothyroxine impacts the lipid exchange, influences this exchange. And you see the level of lipoprotein the LDL, people with different levels. You are all familiar with these threshold recommendations of cardiological communities which were issued in 2019, and you see what targeted levels of LDLs must be so that risk of cardiovascular events would be low. And then you can read it all in the slide based on principle yellow, red, and dark brown. We need to come towards the green color. So when we prescribe levothyroxine to patients with the dysfunction of lipid exchange, we would definitely monitor the level of these indicators reaching the target. Replacement therapy, but levothyroxine reduces not just the level of lipids in the blood, it reduces the level of lipids in the heart itself, in myocard. It's unbelievable effects of the thyroid gland hormone, because the heart function would improve irrespectively of changing the body of the weight mass, because treatment of levothyroxine with patients with manifested hyperthyroidism is proven restoring the heart function, improving the reduce pressure of heart, and irrespectively of changing the body mass or epicardial fat, we see this restoration of the heart function in response to compensation of hyperthyreosis. Very interesting paper. I'm giving a reference to this report. I'm suggesting you study this thoroughly. Given very little time, I cannot go deep into this, but this reduction of lipids in the heart itself, I think this is a phenomena which needs to be studied deeper and promoting more in terms of incorporation of L-tyroxines incorporations into therapy of cardiovascular diseases, of course with patients with hyperthyreosis and patients with subclinical hyperthyreosis. Levothyroxine, how does it impact the heart function? Because we know, and sometimes we're afraid ourselves, that we will prescribe a therapy to an aged person with subclinical hyperthyreosis, and we will worsen something, and CHD would behave worse than before our intervention. We are not alone in these doubts, and our colleagues make research, and we also have randomized clinical research which was published in 2020, and it's also very interesting. Look, they included patients who had age of 65 plus, subclinical hyperthyreosis. They were divided into groups. Initial dose of L-tyroxine was little, and so on and so forth. But average age of these patients was around 74, 75 years. These very patients who are in a risk zone. At the end, systolic and diastolic heart functions did not differentiate it after treatment of levothyroxine with people with subclinical hypothyreosis comparing with placebo of these aged patients. So nothing bad did not happen. But good things, yes. Maybe they will have improving of systolic diastolic functions. What is important, nothing bad happened. For us endocrinologists, it's interesting that the thyroid gland hormones actively participate in regulating glucose metabolism in the cardiomyocytes in the conditions of insulin resistance and diabetes. And we must remember that cardiomyocytes can regulate or self-regulate absorbing energy. It can get energy either initially from fat acids or from glucose. Clearly, getting energy from glucose is a more advanced way. You'll get much more. But fat acids also participate in this process. And you see, we may see a number of problems which through mitochondrial ferments can lead to generating of ATF. What the thyroid gland hormones mean that functions of myocardium regulated by activity of thyroid gland hormones. Thyroid gland hormones promote biogenesis of mitochondria. MT3 improve the mechanisms of substrata in the cardiac tissues because heart is consuming a lot of energy, and ability of heart to switch between the metabolism of fatty acids and glucose supports it. That's why we may see good benefits and will influence the myocard. So as we started to say that T3 influence mitochondria and the processes that happen there and regulate conditions of myocard, we remind ourselves that triiodthyronine is linked with the receptor in the core and creates the complex, receptor complex. Ligand receptor is related with regulatory receptors in the core and create RXRTR. They activate calcium natriurephase to improve the calcium effects that we mentioned earlier for the adequate and diastolic relaxation. And the core compartment, this complex RXRTR, would initiate a big range of genes which modulate the mitochondrial function and B oxidation of fatty acids, which would be the energy for the myocard. It is a very important moment of pathogenetic moment, biological mechanisms of myocard conditions. And looking at this picture, we ask ourselves the question, maybe for hypothyrosis compensation, we need triiodthyronine, which we used to use as a part of combined products, and we stepped away from that now. And this is a question not just we ask, but many other people ask. We have research, but given the huge spectrum of associations and markers that are studied in this context, we have results that we don't see big differences between monotherapy of hypothyrosis of levothyroxine and combined therapy, but including T3 as a part of replacement therapy of hypothyrosis can make a negative impact onto heart condition. And there was a sub-analysis because you can ask, maybe there's a cohort of patients that don't go well for the therapy of levothyroxine. They ask us, and indeed, sub-analysis in the research that I've just mentioned showed there was 1/3 of patients that had most symptomatic hyperthyreosis manifesting clinical symptomatics. And these patients were getting levothyroxine. They got better, subjectively better, when they moved into combined therapy, including TIREO. And why? Authors start to think about it, remembering that TIREO by itself can be absorbed by brain. But most of T3 molecula in brain are made autonomously in glialic cells, and then T3 goes from glial cells, and then they activate expression of certain neuronal genes. And some patients that get monotherapy of LT4 can maintain the hypothyreosis symptoms. Not excluded that LT4 therapy cannot restore completely this cerebral level of T3 among all the patients. It is related with possible defects of transporters of thyroid gland hormones DO2. So the question is open. But if we go back to the lab and clinical criteria that were observed and studied quite often, actually there were no big differences between monotherapy globally of LT4 on one hand and LT4 and combined therapy. Also, as a part of combination, T3 is bad for health. Why? Because such basics, golden basics, there is famous pharmacokinetics of the products in the thyroid gland hormones. And if we see that for levothyroxine, for example, the maximum action is 10-12 days, that for TIREO 2 days. The time of biological half-life is different. Latent time from start of taking until the end for TIREO is 6 hours. It's very quickly, and the person who is in the long hyperthyreosis who gets such a quick product, it would immediately respond to it. First of all, with effects by cardiovascular system, it would be quite dangerous. And you see that TIREO is not used as a monotherapy, but this prescribing the combined products, combined medicines, as many people write, international consensus is some category of people, when you are sure, not what patients think, but you are sure that monotherapy but levothyroxine could be replaced by more active therapy. Talking about TIREO, of course we can say that no way it would be used where there is a risk even for prescribing levothyroxine, where we need special care. Who are these patients? Those who have dysfunction of heart or cardiac rhythm. What are the fibrillation and Wolff Parkinson-White syndrome? These patients are especially sensitive to therapy by levothyroxine. We choose the lower dosages of this product. We observe them more frequently, more regularly, and they might require more often change in the schemes and dosages of using levothyroxine as a part of replacement therapy. These are the patients that have ischemic heart disease and the patients that require very urgent stenocardiac treatment. And the golden rule is, after beginning of cardiological treatment, condition of patient must be stabilized before beginning the therapy by the thyroid gland hormones. If a person has just suffered the myocardial heart attack and we identified myothyrosis, we cannot next day do the compensation, clearly. First, we remove the life-threatening problem, and only then we slowly start compensating the hyperthyreosis. If we are scheduled to have aorta coronary shunting surgery, this could be performed immediately because hyperthyreosis will not impact the post-surgical survivability of this patient. And the identified hyperthyreosis may not be the reason of denying the surgery if it is prescribed.
Повышенный уровень ТТГ. Как вы...
Higher level of TSH, how we set up the strategy by the clinicist. Very good paper dated in 2022, very clear algorithms of the clinical actions depending on who we see, the patients, the age, the problems, and the level of TSH. Just imagine, higher level of TSH. If it is combined with the free higher thyroxine, probably we don't talk about hyperthyreosis here, but we need to talk about the bias, hyperthyreosis of central genesis. We need to remember that the person might have taken levothyroxine before the blood test. It might happen. If a person have a high TSH and normal T4, that's subclinical hyperthyreosis. And here we have separation depending on the TSH and depending the age of the patient. Depending on the TSH and age of the patient, depending on that, we will see the tactics of all the following steps about the levothyroxine treatment and therapy. And look how it changes depending on these two factors, I mean age and TSH level. And the last situation, when the patient has manifested hyperthyreosis, and having manifested hyperthyreosis, of course, is an indication for therapy of levothyroxine immediately without even thinking, without considering the validity or whatever. And here the targeted value of TSH is 0.5 to 2.5 as the person gets replacement therapy. It's good that TSH would be closer to the lower reference threshold, especially if the patient is young or average mid-age. And it's allowed to be a bit higher, from 4 to 6 among the aged people. Manifested hyperthyreosis must be treated. Subclinical hyperthyreosis, you see, treatment would not be prescribed to people with age 85 years plus. All the other, depending on the situation, depending on the TSH level, and the threshold is TSH 7. You've read the slide while I was commenting it. So, prescribing therapy, planning the further tactics, we can be based on these threshold, especially many clinical recommendations, including Russian recommendations for treating hyperthyreosis. They are very, very similar. One more situation that we can say about, especially in the context of discussing the cardiological issues among the patients with hyperthyreosis, is, of course, iodine-induced hyperthyreosis. Most often, in the context of cardiology, we see amiodarone-induced hyperthyreosis. So what's the main thing? The main thing that amiodarone-induced hyperthyreosis often has subclinical character. You see that the mechanism of Wolff-Chaikoff can lead to certain dysfunction of processes and tissues of thyroid gland, you see that genetic precondition and apoptosis development and direct cytotoxic action of the product is a part of pathokinesis, creating amiodarone-induced hyperthyreosis. No matter the reason, we need to remember the main thing. Amiodarone-induced hyperthyreosis does not losing antiarrhythmical efficiency of the product, often has a subclinical character. What shall we do about? First, we need to understand what led the patient to this global condition. Initiation of autoimmune processes in the thyroid gland or any other mechanisms. If there was the autoimmune thyroiditis, it was the levothyroxine prescription, because the classical replacement therapy during lifetime would be required for such patient. If not, we start to think maybe it's possible or not possible to cancel amiodarone in principle. If yes, it is not possible, we will compensate hyperthyreosis and prescribe levothyroxine. If we can cancel amiodarone, then we wait with prescribing LT4, because we remember that hyperthyreosis is subclinical often, and we will look at the TSH level 1 or 2 months after we cancel amiodarone. We can see euthyrosis restoring the function, and we will observe this patient, or we will see strong hyperthyreosis, and then we also prescribe replacement therapy. After canceling amiodarone, euthyrosis would be restored during 2 to 6 months. About this time would be required. That's why the first time, as I said, we define TSH level month or 2 months later. When developing the strong hyperthyreosis, we say and we prescribe a replacement therapy of L-thyroxine following the common rules. If amiodarone is taken by patients for the life indicators, we don't cancel it during development of hyperthyreosis. Under subclinical hyperthyreosis, with the base prescription of amiodarone, L-thyroxine is prescribed under TSH under 10, more than 10. Under pathology of CCC, the early dose of L-thyroxine is 12.5 micrograms. The interval of increasing the dosage for 6 weeks. The purpose is supporting TSH on the upper borderline of the norm without the compensation of cardiac pathology. These principles are based the keeping patient under amiodarone-induced hyperthyreosis. When we treat hyperthyreosis in principle, of course, we remember about those factors which actually influence the TSH indicators and thyroid hormones indicators. There are many factors like that, including age, including smoking, obesity, and macro TSH phenomena, time of taking blood samples. These all can bring corrections into the figures that we see in the analysis forms, and the products, the drugs that patients are taking. Amiodarone that we mentioned could either increase TSH and lead to hyperthyreosis, or reduce it and cause tirotoxicosis. Other things could increase or decrease these TSH level. Products containing biotin or biotin can also do that, and so on and so forth. As patients with cardiological pathology normally receives many different drugs, they have many other somatic diseases normally. We always must evaluate everything in order to correct the correct dosage of L-thyroxine for replacement therapy. We must not forget to tell them about the main things, that they must take products not later than 40 minutes before the food, drink with water, interval with antacids at least 2 hours. Otherwise, we will influence the bioaccessibility of biotiroxine. These are all simple things, but we must explain these to patients. One more thing, which is also very important, because now in the market there are many levothyroxine products, and well, what is the difference? What to choose, what to prescribe, they're all good, not bad. We also discussed this and we studied that, and it's important that the product would be also stored quite adequately in terms of sustainability to different things which can reduce its biological activity. If you take L-thyroxine, which contains lactose, and those which do not contain, and place this L-thyroxine to certain conditions of so-called artificial aging of the product, including temperature of storage a bit higher, humidity a bit higher, etc., etc. The product which does not contain lactose, the one has filling of 2-base calcium phosphate, show better storage effects. It's an important thing because the product are bought, chronic patients, they buy it, they keep it in different conditions on the shelves. Then we start to wonder why, with the right dose, they show wrong indicators of compensation that we are supposed to have. That's why modern L-thyroxine, non-lactose products are good. And some patients also have problems with lactose as well, don't forget it. So Berlin Chemie, L-thyroxine Berlin Chemie is non-lactose product, and we are sure that all of the proper features are manifested in full way when we subscribe them to our patients, especially to patients with cardiovascular problems. So the main thing, if we talk about the main things in treatment, yes, control over adequacy of the replacement therapy is made on the TSH level. LT4 products have very narrow therapeutical range. Calculated dose of LT4 substantially could be different from the needed for reaching the targeted level. That's why we always select the therapy, collecting anamnesis before that for the specific patient, taking into account all the accompanying diseases. We need to remember the substantial ranges in the TSH level in the process of observation require speaking with the patient. We need to understand how they take products. 90% of not reaching compensation are related with poor understanding or no compliance of the patient. If there are clinical grounds, they say everything is fine, then we start looking for the dysfunction of absorptions. We need to remember that changing the brand of LT4 can cause required level of the dosage for compensation related with the composition of the product that I've just mentioned earlier, or some other things. That's why the principle, if it is okay, don't change it. If the patient is okay with one product, don't change it to others, because everything is okay. Don't make these additional maneuvers in its treatment. We must remember that combination of LT4 with theoteranine, if you remember that, could be used only for individual indication as the trial therapy. We need to understand that the proof base of advantages over monotherapy is absent. But patients with cardiac pathology, theoteranine is not used. Hypothyreosis could be easily compensated by prescribing monotherapy by levothyroxine. increasing number of pills always reduces the therapy. And decreasing number of pills at the research show if a person gets one pill a day, the adherence is good. So, thank you for attention. I would like to remember the words of great Russian therapist Mudrov, who said, very simply, if a doctor gives you many different drugs, then the doctor doesn't know what he really helps you. And about hyperthyreosis, when our patients compensating come back to life, improving their cardiometabolical health. Our patients have one product which we can prescribe to them, being fully sure that it would be effective. This is L-Thyroxine, Berlin Chemie, without lactose, which is very good in terms of adherence to treatment, because people don't have to complicate things, several intakes. This is only one time a day. Very good dosage. So we have that. Thank you very much for your attention, dear colleagues, and I am sure that within our discussion, which would be afterwards, would summarize all the questions which were raised earlier by my colleagues during today. We will discuss, and for that we have some more time. Thank you very much for your attention. Thank you very much.
Екатерина Анатольевна.
Ekaterina Anatolyevna, thank you very much. She's in online chat, right? Do we have any? Oh, I'm here with us. Happy to see you. Do we have any questions? I have one question. How long you must take amiodarone, cardarone to have induced hypothyreosis? Amiodarone, it's enough, not long time. One tablet or one pill, amiodarone, has 75 milligrams of iodine. Milligrams. 1 milligram is a lot. And here we have 75 milligrams. 1 month could cause iodine-induced disease of the thyroid gland. So before prescribing amiodarone, you must check the thyroid gland function. Thank you. I make a comment as cardiosurgeon. To patients, we give 1,000 milligrams a dosage, and we observe the pulse. And then we go down to 150 mils. 3 days, 5 days, 5 days, 5 days, not a month. But if among the family doctors or cardiologists, we have those who use months or half a year, we could expect that in choosing the product among the chronic arrhythmia is beta blockers. We cardiologists, amiodarone and cardarone don't prescribe for a long time. Absolutely right. But in life, our patients can get it in years. This is a fact. So, product of choice is beta blocker. We have Professor Leonidas Duntas with a question.
It is so nice to see you after several years. Thank you also for showing us the Institute of Endocrinology in Moscow. I hope very much that the situation will enable me to come and visit you soon in Moscow. Now, thank you for your presentation, and particularly for showing the association of thyroid hormone, thyroid with chronic disease, the so-called non-communicable diseases, which are the cause of 80% of deaths. Primarily cardiovascular disease, dyslipidemia, and arterial hypertension. Then it's diabetes and lung disease and cancer. You have also the various associations. The question, and this is a chronic debate in all the meetings, which is the right moment to support the patient, prescribe thyroxine in patients with latent or also with clinically manifested cardiovascular disease. And here, yes, you have showed us some studies. I like very much the studies showing that what we must try is to reduce the epicardial fat and also to stimulate biogenesis of the mitochondria. So coming back to the whole issue and also the point of your presentation, what would you suggest? I mean, a patient with younger patients below 65 years old, particularly men who are more prone to develop cardiovascular disease or to have a heart infarct. Would you suggest to, and having a TSH, let's say 5.2, 5, not very high, but in this level, borderline increase, would you suggest to treat them, though, and if he has hypo, if he has hypertension and dyslipidemia? I mean, we must clarify some 1-2 points which are a little bit confused in the mind and they influence the practice of clinical doctors.
Спасибо большое.
Thank you very much, dear Professor Duntas. You know, you have touched on a very important question, because if we imagine our modern patient, for example, typical man up to 65, a man with subclinical hyperthyreosis, a man, for example, with obesity, hyperthyroidism as the part of the obesity, this patient has immediately several factors influencing onto cardiovascular problems. That's why with such patient we must try to maintain the level of thyrotropic hormone to the lower borderline of the norm. We need to understand that impact of levothyroxine onto different compartments of fat tissue, including intercardial fat, are obvious today, and it would be just for the better for the patient. Also, we know today that there's a certain thyroid way or thyroid path of regulating under non-alcoholic fat disease for the liver, and this regulation is very important in terms of cardiometabolic risks. Compensating the level of thyroid hormones, we influence this path and we make prophylactics of cardiovascular problems of such patient. Thank you. Other questions?
I would like to keep up the discussion and saying that maybe one factor that has confused and has a little bit influenced our decision is the so-called TRUST study. It was a study initiated in the UK, and they have studied patients with subclinical hypothyroidism over a certain period of time, and they didn't show any effect on this study group. The problem is that nobody has, or not nobody, but it was not in the review, was not enough highlighted that the paper was underpowered. and statistically meaning. And this has, it was in Lancet, it was a very highly promoted publication, but it has methodological issues. And this paper has been cited a lot in the last years, and the 5-6 years it has been published. And this paper has, let's say, majorly influenced our decision in whom to treat. That was a comment. It was not a question to you. That was a comment on our discussion.
Спасибо.
Thank you. In our chat, there were many questions, but I was informed that actually all the questions were answered, except one. Do we have genetic studies in case of inborn hyperidiosis, in case of 2 or more brothers or sisters? Gulnara Ishanovna said, so far not in Uzbekistan, but yes in the world. That's why we have to go to. Gulnara said there is no reference, but there is a big area for us to start a joint work to define the TSH level in population. Then we can resolve many problems. So that's also I wanted to add. Actually, we are fitting our part of now what we said. This is the. Can you put the slide, please? TIREO Academy. At the first, was the organizer was Said Gani Ibragimovich, and then we have high disease because we have in thyroid condition. It reduces intellectual ability of our population, not the nation, but the population. First of all, can you give me remote control? I'd like to thank Berlin Chemie I would like to thank you for bringing us together. We had 150 people, plus 50 more online, 200 total. If we have 700 in total in the country, we have 30% here. It's so important. We spoke with Professor. May 25 is the world. Oh, Yelena Anatolievna, sorry, Ekaterina Anatolievna. Ekaterina Anatolievna, we may let you go if you're not interested with us. Thank you very much. Oh, I'm very interested with you. I'm with you so far. I will switch the camera off. Look, even the world is celebrating the World Thyroid Gland Day. Ekaterina Anatolievna would be happy with us. She is the follower of Mr. Islambekov, our teacher. Mr. Sadiq Masumov is the person who established our endocrinology institute. I will tell you more about him. He developed exchange of iodine, and also we have Professor Turakulov. He is on the left. He is the father of our endocrinology, and his colleague Rajab Kaplanovich Islambekov. So these are historic things, why we had to do issues of thyroid gland. Even Napoleon proved how low Swiss citizens are, but now we follow Swiss time. All the population is almost 8 billion, and because of the lack of iodine, we have 43 million people, and 760 million people have goiter. For our 3.5 million subscribers have one doctor. I'm going to show 10% of our population in the country. And let me show you this. There was the IQ paper, and I like this photograph. Surgical. On the left, to the right, a photograph of embryo of rat, neuron with no iodine deficit, and the one with iodine deficit. If any pregnant woman comes to you and you show her this photograph, she will take iodine anyway. We understand better through watching than listening. So we prefer to have photographs. And this group of risk, we doctors, we represent intellectual top of the nation. We must bring knowledge to all the population, mothers and pregnant women and kids. Talking about cardiosurgery, I found this article back in 2018. Look what people were showing the figures. This is a very simple picture. Thyroid gland. Influences blood vessels, hypertension, sclerosis, coronary artery stenosis, heart failure, vascular thrombosis. If we do well, there will be no risks will happen. Talking about the nutrition, there's no much iodine in food. We won't be able to eat so many nuts. We need medicines. We spoke with salt, how important the salt is for prevention. Nasiba Usmanovna keeps telling me this is systematic mass prevention. Back in 2016 we had that figures, we had the special report. In 6 years we have reached in the country for moving into adequate salt content, iodine deficit condition, but alas, this is something that we have achieved. And these are the figures of 2022. Then the Minister Musayev was the minister, and he had a decree to check the salt. 47% of salt producers don't put iodine at all. Our people think, I bought salt and I won't have iodine deficit. And we keep saying, Musayev was so bad. We need to make sure that there is iodine in salt. And we removed 50 tons of salt from sales, from shops. How can we explain this? Only you doctors can explain this to people. This number of households, 10 million households. Can you imagine how many people were using not iodine salt? And this person in 2006 put down preventing methods. Potassium iodide, based on his teachers. He organized the Iodine Academy to avoid these situations with these goiters, to avoid people with low intellect. People do it in the world. You see with yellow, Canada, Australia, New Zealand. There are no problems in Japan. That's why they're so smart, really. They don't have hyperthyreosis, you see. And we are listening to doctors. They tell us to work with the wrong organizations. They don't understand that inside there's also iodine, but different products. Or this guy, 3,500 subscribers. Let me tell you a secret. Don't be surprised why I do that. I was fed well when I was a kid. Maybe that's why I have intellect like a criminal investigator. He has 10 professions. I'm a cardiosurgeon. I work for 25 years. And he has so many diplomas. So many diplomas. There's no confirmation, no proof. He has 3.5 million subscribers, 10% of our population in the country. And look at this diploma from the Russian stamp, Red Square, 27th of December 2019. He studied for 3 months ultrasound in St. Petersburg. Same time he studied in Izhevsk, sexologist. And look at the difference between Izhevsk and St. Petersburg. And 3.5 million subscribers are listening to this guy. And he says the iodine is poisoning. And it is not funny, we must cry that 10% of our population are listening to this guy. They don't use iodine. As a result, they have iodine deficit. He said, he was reading this article, he said, we are prepared to work with you. How can a person study in 2 places at the same time with 1,369 kilometers at difference between this? One girl said, I'm a subscriber to this guy. She said, come on, we can teach online. We have illiterate people who are listening to the illiterate doctors online. These guys manifest iodine deficit. That's why, and look, other business empires would fight with us because they offer to iodide the flour, crackers this, iodide that. And how business empires fight against that. Russia have big production plants of Coca-Cola and Черноголовка. They compete with each other. Potassium iodide improve intellect. That's why our president made this program. He can see this pain. If we don't fight against illiterate doctors, we will have people with no brains and they'll go to war. Did Japanese people had wars recently, or Switzerland? No, because they never had iodine deficit. That's why must we continue work promoting people. Professor Turakulov, he was nominated to Nobel Prize twice. He was researching thyroid hormones. When we had a genetic guy from Harvard, I told him, please develop your diabetic center. I said, ask this question. Maybe the award would find its hero even afterwards. There are 2 letters that this guy was nominated to Nobel Prize. And in 1999 in Geneva, they said, removing iodine deficit would be as triumph like polio. I don't know whether I fit into time or not, for you to judge. Thank you for listening to me till the end. And once again, my speakers would be glad to say thanks to the company.
Let me say that really I am happy and somehow emotional at the end of this meeting. It was, as I have promised you at the beginning, a great event, a very important event. We are, I think, all together happy that you have participated, actively participated. We have received so many questions. And I think that the whole atmosphere was very good, it was exciting. And we have learned a lot, we have reviewed many things in clinical thyroidology. And do not forget that what united us is the thyroid gland. And it is on the neck, it is between the brain and the rest of the body. And this makes thyroidology the most important of all the other sub-specialities of endocrinology, if not of internal medicine. Though here my colleague cardiologists may have some objections. But we feel that the thyroidology is very important. And this atmosphere, you can find it more than in any other society. If you have visited, participated other societies, there is no such an atmosphere among all the participants as is in thyroid sections. So with these last words, I would like very much to thank you for being here so numerous, coming from, I think, from mainly from Tashkent, but also from other regions of the country. I would like again thank Berlin Chemie for having make possible this event. And last but not at least, Professor, I must say it correctly, Hulevich, for chairing, and also Professor Akhimova, and dear Katerina Trosina in Moscow for their participation, interaction, contribution, and thank you all once again.
I can join all the wishes of Mr. Turaev, Dr. Duntas. I will not add anything. I will just support these two very sincere words of thanks to our endocrinologists. Thank you all, and thank you, Berlin Chemie, for that. Ekaterina Anatolievna, I'm so happy that you're with us. Yes. Yes, dear colleagues, I will not say much. I was talking too much already. I'd like to remind you that harmony is in hormones. We have eternal problems which must unite us. Health of our patients is a reason for us to unite efforts. And Uzbekistan is a country with great traditions and achievements in many things. I would like to thank Berlin Chemie, and I think that ahead of us we have many common things, in particular in monitoring the natural deficit in Uzbekistan. In Russia we have similar problems. Thank you, dear colleagues. Thank you very much to all the participants. We'll have certificates coming, so we believe that our conference made possible, and we would like to invite everybody for a gala dinner. Don't forget to give your headsets, I would like, otherwise you'll not get your documents back. you.